to our 10th lecture. Today we're going to be talking about sexual dysfunctions, paraphilic disorders, and gender dysphoria. So the whole variety of psychological disorders outlined in the DSM-5 surrounding human sexuality for the most part. And in doing so, we're talking about abnormal psychology, and in this case, we're specifically talking about, abnormal expressions of human sexuality. Then we need to know what is normal. We need to establish a baseline. So we're going to talk a little bit about that. We're going to do an overview of the various different types of sexual dysfunctions that are, lined out in the DSM-5. We're going to talk about how do you assess someone's sexual behavior. This is as there is with many things we're going to discuss in this class, there's a lot of avenues and ways to assess. There's physiological assessment, there's psychological assessment. So part of the issue then is to figure out how to establish comfortable conversations about what can be sensitive topics and learn how to get good information from individuals so you can actually help them and get past some of the stigma or discomfort that might come along with talking about these types of things. We're going to talk about once you've established that, once you've assessed the person's behavior and perhaps identified a potential disorder, how do we go about treating it and where do we think it comes from in the first place? We're then going to move on and talk about paraphilic disorders, what the clinical descriptions of those are, how do you assess them, how do you treat them, and then finally we're going to talk a little bit about gender dysphoria. So there are a set of disorders within this heading called gender identity disorders, and I think it's really important that we talk about what's normal versus abnormal sexual behavior. And when we're doing that, we need to be very mindful of any biases, whether they're cultural or whatever that we may be bringing to the table. That our assessments need to be based upon the science of psychology as we apply it to other things like depression and anxiety. So we do talk about norms, normative, when you think about human behavior being typically distributed under the bell curve, that the majority of the people tend to be average, so to speak. There's a clustering of variance around the mean. And so is it normative to engage in certain sexual behaviors? Well, we don't know that until we establish normative data. So we need to look at, sort of facts and statistics to have a real sense of what quote unquote normal sexuality looks like. We need to consider cultural context because obviously, a whole huge aspect of our culture surrounds relationships and sexuality and expressions thereof and gender as well. So, these are all topics that need to be considered in terms of the cultural context. And then we'll talk a little bit about gender differences in sexual behavior and attitudes. So, these are just a couple of slides from your book. I will mention that there's a whole great amount of data, in your book, and also some links to some good resources. If you have questions about what constitutes normal human sexual behavior, there are wonderful places to go to get good research based on that. But this looks at things like differences between men and women in terms of which percentage had experienced various types of sex, whether it's having oral sex or vaginal intercourse. This gives you sort of an indication of when people are becoming sexually active or quote unquote losing their virginity, so to speak. We also see that, you can look down below, we get this breakdown of certain types of sex acts between men and women, which are relatively similar. So, we can look at gender differences, but I do want to talk about something larger in the context of this class for a moment. And that's why I really think, language is important. We are in a revolutionary stage of language where people that have generally been socially stigmatized or disregarded or disempowered by culture are hopefully being invited to the table to sort of explain and offer their preferred language. And so we're getting into, this was International Pronoun Day just recently. So we're getting into this idea of allowing people a greater sense of self-determination in terms of their gender identity. And I think that is a positive step forward. So we really want you to, be mindful of language. I want you to be mindful of language in all sense, not just regarding these, gender identity issues, but I think in general, we need to be more careful and more deliberate and more specific with our language. Language is our tool for understanding the world, essentially. A lot of our major endeavors, like science, spring from language, by our ability to express ourselves, whether it's out loud or through writing. There's plenty of evidence that says that our memories and our understanding of the world switch to being linguistic when we acquire language as children, which is why you forget a lot of your memories from when you're an infant or a toddler. So language is vitally important. And so there are terms that are defined in the DSM-5, which we know we'll talk about in a moment, are slow to change, right? They are not always at the bleeding edge of what is essentially considered, appropriate in that time. But I want to make a distinction between those terms and terms preferred by marginalized groups. So, at the time of the writing of your textbook, they talk about how the acronym LGBTQ or LGBTQI or LGBT plus, whatever you want to adopt to try and be most inclusive. This was a common term, but the idea was that they're writing about research and about terminology from the DSM, which sometimes is not going to line up with that. So, I'm not trying to raise this to make an issue of it, but merely to plant the seed that, language is important, and the way that we as psychologists define and refer to behaviors and certain activities and certain, aspects of psychology has repercussions for the greater good or greater harm. And so I do think we should always be mindful of how we utilize language in abnormal psychology to try and to destigmatize things, to not sort of label someone as the other. Rather, we're simply trying to help them by identifying the issue and hopefully, recommending an effective treatment. So, as I said, some normative data helps to kind of get a sense of where we are. So these are just some examples. Now your book has a lot of other data, as I mentioned, but like these are just some that are pulled from that. So you can assess people's quote unquote normal sexual behavior by doing large scale surveys of large populations and hopefully representative populations, or representative samples of the larger population. And as you can imagine, there's a lot of thinking and a lot of analysis that goes into how do we assess sexual behavior, especially given the stigma associated. Do people overreport? Do they underreport? So what are we essentially trying to, how do we do our best to get valid data? Putting all that aside for a moment, these are just some examples. Okay, so for example, for lifetime, to have 15 or more partners is a little less than a quarter of males reported that. About 8% of females reported that. 4 or more partners in the past year, also quite rare for both men and women, but slightly more common for men. Homosexual sex attraction or behavior hovers around 9 to 10%. There is a lot of research about the prevalence of homosexuality, this idea, and of course, especially as we start to be a little more sort of good with our language and more explicit, and we get away from sort of dichotomies of homosexual versus heterosexual. But all that aside for a moment, there's some really interesting research on people that identify as LGBTQ or not, and some of the numbers that were originally indicated seem to be tapping more into sex attraction versus just behavior. So this idea that perhaps we have overestimated the number of people in populations who identify as homosexual. Nevertheless, you are dealing with minority groups by virtue of the demographics. And so I think it is important that we try to be accurate to understand the representation of people in our culture. One issue that I deal with as a geropsychologist, of course, is a lot of biases and stigma against older people. One of which is that, older people are not sexual beings, do not engage in sexual behavior. We know that plenty of individuals can continue to engage in sexual behavior past age 80. So amongst 75 to 85-year-olds, we see that a little less than 40% of males are active and a little, 16% of females are active. We do know there is a decrease in sexual activity as people get older, especially as they become more geriatric or elderly, just because of physicality, right? As their bodies are changing, as they're dealing with more health issues and less mobility. We find that people might not be able to physically comfortably have sex, or it might be very difficult for them to do so. And of course, there's plenty of health conditions that can make it difficult to engage in sexual behavior, especially amongst men as they get older. So I'm talking about various forms of erectile disorder and such. So, but I think it's important to keep in mind that that does not mean that people's sexual identity, their attraction to others, their being a sexual being, so to speak, ceases when you reach a certain age. And so that's an important bias I want us all to be mindful of. Some examples of more data like gender differences in masturbation. We know that about 3/4 of males report ever masturbating in their lives, and a little under half of females report ever masturbating. So why is this important data? Well, it helps us to understand the differences in male and female identified sexuality. And so we have sort of theories about this discrepancy. Certainly, like the mechanics involved seem to be, simpler for men than women, just based upon the physiology. And of course, perhaps the idea that men are more focused on physical gratification as opposed to emotional intimacy. So there's plenty of theory, amongst researchers about why this is, but we do know there are all these discrepancies, and that can sometimes be at the root of, if not sexual disorders in clinical psychology, certainly just relationship discord that surrounds issues about sex. So I think that's an important thing to be mindful of as well. A big part of couples counseling often involves conflicts about sexuality and sort of different appetites for sexuality, different libidos, different interests, different willingness or lack of willingness to engage in certain things. And so it can be a huge part of what we do when we work with relationships and couples especially. Let's take a look at some differences across gender in terms of sexual frequency. Historically, men had been more likely to engage in casual premarital sex than women, but that gap is shrinking and approaching parity as time goes on. We do know that, at least stereotypically across genders, there are some different drives, different elements of what are associated with sexual satisfaction. Again, some of these are stereotypes, but of course, some of these stereotypes are backed up by some data. Not that you can paint everyone with this brush, but that there certainly seem to be these trends across gender. That women are more likely to seek demonstrations of love and physical and emotional intimacy. Men are more likely to focus on arousal. A tale as old as time. I'm not telling you anything you probably don't already know. There don't seem to be major differences across gender in a few domains in terms of acceptability of homosexuality, acceptability of masturbation, and the importance of sexual satisfaction. So flying in the face of some of those stereotypes taken to extreme, we can start to understand that we do share a lot of characteristics across gender in terms of what we look for in terms of sexual behavior. So there's an important distinction, of course, to be made between sex and gender. We now are coming to understand more effectively, even as a culture, that sex often refers to sort of biological determination or physicality, whereas gender is more of a psychological construct. And so we may have gender differences in terms of our sexual beliefs and how we think about it. So there's something called a sexual self-schema, which is basically the framework or the way you've constructed your understanding about your own sexuality. And we know that females are more likely to value experiences of passionate and romantic feelings. The research has shown that the minority of women hold embarrassed, conservative, or self-conscious views towards sex. Males have fewer negative core beliefs about sex and are more likely to emphasize, sort of more aggressive aspects of sexuality like dominance and aggression. So men show more sexual desire and arousal based upon certain physiological evidence. And we know that self-concept often includes things like power, independence, sort of being virile in the traditional machismo sense. Women emphasize the context of the sexual behavior, so specifically committed relationships for many. Sexual beliefs are more easily shaped by cultural, situational, and social factors in women. That is not, I think your initial interpretation of that fact could be, or that statement could be, that it's detrimental or that this is negative. In fact, it's actually quite positive, meaning that women are more able to adjust their understanding of sexuality and their beliefs about it based upon experience and based upon context, whereas men tend to be more rigid in their understandings about things surrounding sex. So there's an entire class to be taught on the cultural differences regarding sexuality that's really outside of the scope of this class. Your book does a pretty decent job of talking about some of these issues. But like I said, it's an entire area of study unto itself in anthropology and sociology. But these are just some kind of examples of how things that can be very discrepant from the traditional Western perspective on sexuality are not necessarily neither right nor wrong. We're not applying a moral lens to this. We're just talking about how things can be very diverse in terms of what's considered appropriate. So the Sambia people in Papua New Guinea, they believe that receiving semen contributes to development in children. So they emphasize homosexual oral sex between teenage and young boys, something that in the United States would obviously be a crime and would be something that would be considered completely inappropriate. In India, there is one region where there's an emphasis on mild heterosexual activity like mutual masturbation amongst cohabiting children of different genders, by the way. So permissiveness towards casual sex varies across culture, and I think, even just within the West, comparing sort of like some European communities to American standards is a massive shift even. So I think it is important to always consider the cultural context of what constitutes a disorder or not, and we'll bring out a few examples of those throughout this chapter. So a lot of research, a lot of interest in the development of sexual orientation. So this is a bit of a cop out, but I think it's an accurate one, which is that, like a lot of things in psychology, we've come to understand that it's the product of many, many influences. So this biopsychosocial model is applied. We do know that homosexuality has a genetic component, but that it is not a huge genetic component. So there's only a 50% concordance rate between identical twins for the same sexual orientation, which would imply there's a relatively small genetic influence. Nevertheless, we do believe that there are some strong biological influences on the development of sexual orientation. So the jury is still out as to what those mechanisms necessarily are. But again, it's considered to be something that is multidimensional and determined by a lot of different forces. I want to take a brief detour and talk quickly about the history of homosexuality as a disorder in DSM history. So this is obviously something that points to the changing mores and the progression of our understanding about human behavior and human sexuality specifically. Prior to DSM-3R, which is we're talking about like 70s, 80s, 1970s, 1980s, homosexuality was still listed as a disorder within the DSM, keeping in mind as long as it was causing the individual significant impairment in functioning or distress. But nevertheless, we now, of course, believe that this was inappropriate and based on a lot of stigma and bias. There is some research that basically demystifies the distinction between hetero and homosexual attraction. And so we know there are no real physiological differences in arousal between homosexual and heterosexual individuals. There's no difference in the rate of psychological disturbance. Certainly you do see, cultural pressures that cause or influence certain psychological disorders to develop amongst people that are stigmatized or marginalized, but no overall difference in terms of the likelihood to develop mental disorders. Gender identity confusion is no more common in homosexuals than it is in heterosexuals. And because of a lack of full social acceptance, of course, we know that homosexual concerns may differ significantly from heterosexuals' concerns regarding and surrounding sexuality. So again, we have to consider the context that these behaviors exist in. The point being, though, the reason why I bring it up is that there is obviously an evolution within our taxonomy, within the way we label disorders. And I'm sure there are things that we are labeling disorders today that we may disagree 20, 30 years from now that these constitute disorders. You're starting to see this, I think, to a certain extent within the autism community. So there is this. First of all, there's been a massive shift, and we'll talk about this in that chapter, but just briefly to show that evolution. There's been a massive shift in, first of all, autism being regarded as a categorical diagnosis versus a dimensional one. It's been one of those places where that fight has been well fought. And so now we've sort of got this idea that there is the autism spectrum, and there are plenty of high functioning people who meet diagnostic criteria who would take issue, who are not distressed, who are functioning relatively well, who would take issue with it being labeled a disorder. So that might be the next battleground for places where we start to see some more positive psychology understanding of certain behaviors that are not distressing, that don't impair functioning. But basically, this is an example of how the DSM has evolved, and for the better, in my opinion. We also know this idea that, assigning someone a diagnosis of a sexual dysfunction, if they're non-distressed, if they're functioning relatively well, how does that impact their well-being? Is there a negative sort of impact of simply making that diagnosis? And are there any benefits to assigning a diagnosis that is not associated with present distress or impairment in functioning? And for the most part, no. We're going to talk about one sort of exception. Well, I shouldn't say an exception, but in personality disorders, often people do not experience distress. They do experience impairment in functioning a lot of times. But we'll get to that one in chapter 12. So let's talk about the types of sexual dysfunctions that are outlined in the DSM, they tend to surround certain aspects of the human sexual cycle. So they usually involve aspects of sexual desire or interest, sexual arousal, sort of when engaged within the act of sex, the ability to become aroused, and or orgasm sort of as the culmination of this cycle, or the beginning of the cycle beginning again. But we also know that there are people who have pain associated with sex, especially this is more common in women than in men, and that this can lead to additional dysfunction in sexual behavior. So it must be present for 6+ months in order to make a diagnosis in DSM-5. So we're getting back to this idea of it needs to be a persistent problem, not an acute or episodic problem, before we really consider it a disorder. I think what that's intended to do is to normalize fluctuations, or the fact that some people go through periods of time where they're under more stress, where they do have some issues with these experiences. But essentially, what we know is that it needs to be something that is persistent and chronic before we want to call it a diagnosis. And it must lead to impairment or distress in order to be considered a disorder. That's emphasized, I think, especially so. That's something we discuss in every chapter about different types of diagnoses. But in the case of sexual behavior, I think we're being more sensitive of recognizing that something that does not cause distress and doesn't lead to impairment is not a disorder, and therefore should not be labeled as such. So this is a figure from your book that sort of outlines the various phases of human sexuality, human sexual behavior. So this is a progression from an initial state of desire, which can be in response to cues or just fantasies, the arousal phase, and then the plateau phase of engagement in sex, eventually leading to an orgasm phase, which of course, there's differences across gender regarding orgasm. We're going to touch on a little bit in some of these disorders, and then the resolution phase, and then the continuity of this cycle. But what we find is that the different types of things that are designated within the DSM as disorders can usually be associated with one of these phases. So we'll sometimes refer to it as a disorder of arousal, or a disorder of desire, or an orgasmic disorder. So we're essentially giving it some context and some placement within this cycle to designate what type of disorder it is within sexual dysfunction. So some degree, again, everything along a continuum, less categorical diagnosis is the goal. We do know that sexual difficulties are extremely common and are not always distressing or leading to significant impairment. One study found that 40% of men had some difficulty with erection or ejaculation throughout their life. 63% of women had problems with arousal or orgasm at some point during their life. So we're talking about something that is really quite common. In some cases, this is just part of the normal spectrum of human experience. It's really when it becomes chronic and persistent and leads to more distress that we start to think about whether or not this is a disorder. Interestingly enough, males and females experience parallel versions of most dysfunctions. There are some, and again, I apologize for that harsh dichotomy, but that's sort of the way the research is still structured for the most part to this day. But there are parallel versions for a lot of these disorders, with a couple of exceptions, which are really come down to physiology and differences between men and women. So how do we classify a sexual dysfunction? We want to talk about whether it is lifelong versus acquired. So is it something that, seems to have been dispositional, or what did it come about as a result of something that happened to that person in their life? Is it generalized, meaning does it happen all the time in every sexual situation, or is it situational specific or cued by a particular situation? We want to know whether or not it involves something physiological that's causing the problem versus something psychological, because of course the treatments are very different in many cases. So is it a psychological factor alone, or is it a psychological factor combining with a medical condition that really is at the essence of that particular disorder? So the first one we're going to talk about is what's called male hypoactive sexual desire disorder. So remember that when we utilize the prefixes hyper and hypo, if you remember hypomania, meaning sort of like less significant, less severe, hypotension is low blood pressure, hypertension is high blood pressure. So hypoactive meaning an underactive sexual desire disorder in men. This is basically characterized by men who have little or no interest in any type of sexual activity. And that doesn't just involve partners, but masturbation, sexual fantasies, and intercourse are quite rare. It accounts for about half of all the complaints at sexuality clinics, right? So this is sort of the more garden variety thing you're more likely to see as a clinical psychologist in those settings, and seems to affect about 5% of men as far as lifetime prevalence goes. We're going to breeze through a lot of these, and we're not, of course, there's a whole class to be taught, on each of these disorders if this is the area that you focus in clinically. But I want to just give you sort of the 30,000 foot view of these various disorders so that we have an opportunity to kind of, you know, become familiar with all of them rather than deep diving into anything specific. Erectile disorder, of course, mostly because of the pharmaceutical industry, is something that people are much more aware of, or at least they're more willing to discuss and give it a medical label like male ED or erectile disorder. A lot of times in the medical field, you'll see it called male ED. Um, this is basically difficulty achieving or maintaining an erection when desired for sexual activity. Sexual desire is usually intact, which of course is why there is often distress associated with this. If someone, has an hypoactive interest in sexuality and physiologically is not able to perform, it's less of a conflict. But if you want to be a sexual person, if you want to engage in sexual behavior and you're physically not able to, well, then there's your frustration factor, right? There's your distress. It is the most common problem for which men seek treatment. Insert stale old stand-up joke here, about the idea of men willing to seek help for medical conditions, and their lack thereof. The prevalence does, of course, increase with age. This is really mostly likely due to hypertension and other cardiovascular functioning over life because, male erections and female arousal are both very closely tied to blood flow. And so anytime you've got any cardiovascular issues like those that become much more common as you get older, you're more likely to see this. So 60% of men over 60 experience some degree of erectile dysfunction. Again, very widespread common conditions. So let's talk about female sexual interest arousal disorder. This is basically hypoactive arousal disorder or interest disorder for women as well. Now, before we even jump into this, I think it's really crucial to stop for a minute and again, always consider the sociocultural context. Psychology for its first, several decades is, like most sciences at the time, very male dominated and therefore maybe more prone than even other disciplines to sort of misogynistic beliefs. So I want to get away from sort of this old-fashioned Freudian idea of women being quote unquote frigid or hysteria, as a focus of women. I think it's a really dangerous stereotype that we're trying to rid ourselves of. But on the flip side of that, I think in a more progressive and more modern understanding is the idea that no, we now understand that of course women have an interest in sexual satisfaction on the average, that the majority do. We used to be sort of much more upside down, I think, in our understanding and agency of women as sexual creatures. So that being said, if there's a discrepancy where the person has a lack of interest or arousal and that causes them distress or it causes impairment in their relationship, for example, if there's a mismatch of level of desire, then perhaps we start to talk about it being a disorder. Regardless, a lack of interest in or a significantly reduced sexual interest or arousal is typically manifested as reduced sexual interest, reduced sexual activity, fewer sexual thoughts, reduced arousal to sexual cues, and reduced pleasure or sensations during almost all sexual encounters. So getting back to that idea of it's not a disorder if it doesn't cause distress or impairment in functioning, it's very easy to imagine someone who along the continuum of human sexuality has a very low level of desire and is perfectly fine with that. They may identify as asexual or not. They may be in a relationship that has a sexual component to it, and this is creating conflict, or they may be in a relationship with someone who has a similar level of interest in sex. And so it's not necessarily a disorder until that person is experiencing it as something distressing, or they find that it impairs other aspects of their life that they want to function well, like relationships, for example. Female orgasmic disorder is the marked delay, absence, or decreased intensity of orgasm in almost all sexual encounters. So again, it needs to be prevalent, needs to be chronic. It's not explained by relationship distress or other significant stressors. I think this is a really important qualifier, and this can be applied to both men and women, of course. If the person is under significant stress, if the relationship itself has a lot of discord, then we don't want to sort of start blaming the individual for having, an orgasmic disorder. It might be that the context makes it very difficult for that person to be in touch with themselves sexually, and that's not necessarily a disorder. That's a circumstantial problem, right? We do know that 1 in 4 women have significant difficulty achieving orgasm, so this is, again, a quite common problem. And for many women who want to have and define a satisfying sex life as involving orgasm, which is, perfectly rational, that's where this becomes a disorder, because there's a sense that I want to seek treatment for something in my sexual experience that is not meeting my expectations or what I want my sex life to be like. So that's really where you see the distress, and often where you see women seeking treatment. Premature ejaculation, of course, is defined as a disorder in terms of occurring within 1 minute of penetration, roughly 1 minute of penetration, or before it is desired. And that's a very subjective measurement, I think. So, you have to kind of consider the physiology and the context, the person's subjective expectation of what sex should be like. You do occasionally have people, claiming that they're having a problem with premature ejaculation, and then you ask some questions during an assessment of their sexual behavior, and as it turns out, they are quite within the normal range. It's simply that they have an unreasonable expectation about sex, or they may have sort of a discrepancy between their partner and themselves. Sometimes it's just a matter of education. I distinctly remember when I was a practicum student, when I was in graduate school, having an older couple who came to us to help with their sexual relationship, and working with them, and then finding out that it was not so much there was anything really wrong with their sex life, so much as that they needed some education about sex and behavior in general. They had kind of come from a very impoverished setting and were largely ignorant of some things that we all kind of take for granted, understanding about sex. And more importantly, I think they both had they didn't understand that they were well within the normal range. They kind of had some unrealistic expectations. So education goes quite a long way in treatment of some of these conditions, or even identifying whether or not it's a disorder. That being said, this is the most prevalent sexual dysfunction in adult males, affects about 21% of all adult males at some point in their life. It's most common in younger, inexperienced men, and the problem tends to decline with age as time goes on. So again, is it a disorder, or is it an isolated incident? I think really it starts to become a disorder when it's persistent for 6 or more months, when it tends to be the issue in almost all sexual encounters. Genitopelvic pain or penetration disorder is a condition associated with women where there's difficulty with vaginal penetration during intercourse, associated with one or more of the following. So experiencing pain during intercourse or during attempts for penetration, fear, anxiety about pain during sexual activity. So this kind of follows that same pattern in some ways that panic disorder can, where you have this really aversive experience, and then your anxiety becomes about avoiding that aversive experience or enduring it with distress. So you get into the women who are experiencing this can sometimes be in a negative feedback loop, where they have these negative experiences where they have discomfort or pain, and then when sexual activity is initiated, that anxiety ramps up of re-experiencing that, which only serves to kind of reinforce the problem a little bit. It can involve the tensing of the pelvic floor muscles in anticipation of sexual activity. So sort of muscle tension, physiological tension associated with the act. Again, aversion to pain or discomfort. So it really is someone who's trying or wants to have, healthy penetrative sex and enjoy their sex life, but they're having this physiological difficulty doing so. And more to the point, significant discomfort and or pain associated with it. So how do we assess sexual behavior? I think as psychologists, hopefully we are modeling comfort and acceptance in discussions about sex. I think that is the very first thing that we can do as clinicians to help people to have healthier, better functioning in their sex lives. there's so much stigma, so many cultural and societal pressures involved in how we think and talk and discuss sex in general. So I think it's really important for psychologists to hopefully create an environment where people feel safe and they feel valued and seen, and they understand that they can trust this individual to talk candidly, because if the person is withholding information, it makes it extremely difficult to help them, and often it makes it very difficult for them to understand what the problem is and how to approach it. So creating an environment of therapeutic alliance and trust, and the person understanding confidentiality and all those aspects of treatment really helps to get the ball rolling and get these conversations started. So you have to demonstrate comfort with the topic. You have to feel comfortable talking about it. And you need to assess multiple dimensions, not just the problem itself as it's being presented, but the person's sexual attitudes. What is their sex life like behaviorally? How do they go through that sexual response cycle? So where in that cycle are they having a problem, so we can start to narrow in on possible diagnosis? You want to talk about the health of the relationships that they're in themselves. You want to sort of understand, is there a lot of discord or stress or domestic dispute within this relationship or not? Is it a healthy relationship? Do they have physical health issues? This is really important. And sometimes what you're going to do is refer them to go to their primary care provider or to have a physiological, physical conducted. And then, of course, what are any comorbid other psychological disorders that these individuals are dealing with? So in addition to the more psychological assessment, the clinical interview or conversation that you have with a patient, there are some other ways we need to assess sexual behavior, including medical exams. So there are a number of physiological factors that can impair sexual functioning, the most obvious one being medication side effects and other physical conditions, like I mentioned, cardiovascular issues. So there is a physiological assessment that needs to happen, which is usually done by a medical provider of some kind. And then what's called a psychophysiological assessment is another possibility. Now, this is done a lot more in research settings, but also you do see these clinically applied for people when you're trying to understand the nature of the sexual disorder they're dealing with. But you can use various types of measurements to get sexual arousal data, in response to erotic material. So there's something called a penile strain gauge, which measures erection. There's also a plethysmograph. And then with women, there's what's called the vaginal photoplethysmograph, which actually uses a light cell to measure blood flow in the vagina, which is, a physiological indicator of arousal. So these tests are not very commonly used, but when they are, it's a way to sort of differentiate a physiological problem from a psychological problem. Is there something going on as far as your cardiovascular functioning that's making sex difficult for you, or is this something that's more psychological in nature? That being said, we do know there are biological causes to a lot of problems in the sexual response cycle. So various physical diseases, cardiovascular diseases being on top of that list, diabetes being on that list. There's lots of different chronic illnesses that can affect, blood flow and other aspects of sexual functioning. There are plenty of prescription medications that can affect sexual function. Antihypertensive medications, so the things you take for high blood pressure can in fact have the side effect of affecting males and females, blood flow to the genitals. So that can be an issue. One other interesting one, of course, is some of the antidepressant medications, especially the SSRIs, for some people have a negative effect on libido. So you want to know, does the person have a comorbid psychological disorder that they're taking a medication for that is having the positive psychoactive impact on their depression or anxiety, for example, but is negatively impacting their physiological functioning and therefore their sexual behavior. And of course, alcohol and other drugs we need to always assess for, because they can all have an impact as well. As far as psychological contributions, we know that people, this is again a correlation, not causality, but people with sexual dysfunctions tend to be more anxious individuals. They tend to have more negative thoughts and expectancies surrounding sexual encounters, which should make some sense. That this idea that for better or worse, people's sexuality and what goes on psychologically in that process is often quite complex, and is probably for some people relatively fragile and prone to being upended by anxiety or fear or sadness even. So the person may actively avoid awareness of sexual cues because of this. So men with men with erectile dysfunction tend to distract themselves purposely to avoid orgasm. And so what's happening is the person is kind of like they're conditioning themselves in an unhealthy fashion over time. So indirectly, unintentionally, they're creating a conditioning response that then leads to an erectile problem because of this focus on trying not to experience premature ejaculation. So the way we wire ourselves through the way we think can have an impact on our sexual function as well. Of course, anxiety plays a huge role, especially when it comes to sexual arousal. So we know that anxiety in many cases decreases arousal and contributes to sexual dysfunction. But in some cases, what it can actually do, that fine line between anxiety and arousal, right? So arousal can be applied to sexuality as being sexually aroused, but within the sort of larger biological, neurobiological context, when we talk about arousal, what we really mean is an excitatory response in the brain. A threat can create arousal in the brain, right? Or something frightening. So we know that there is some association of anxiety, maybe a healthy degree of anticipation, or some people who, their sexuality is wrapped up in the idea of unknowns or of things being tense, because it creates this heightened awareness. So it's not clear that anxiety is always a problem in terms of sexual dysfunction and arousal. We know that distraction increases arousal and awareness of your own sexual response. So there's a lot of concentration and focus that some people require to engage sexually, and if they're having issues in that realm, it can also cause problems. So this is a figure from your book this is 10.5, that's sort of talking about functional versus dysfunctional sexual arousal. So things like positive affect. So are you feeling hopeful about yourself, about the future, about the relationship? Do you feel in control? Do you have an internal locus of control regarding your own expression of sexuality? Do you have the attentional focus to erotic cues? Are you having that autonomic response physiologically? And then are you able to attend to those erotic cues and perform, and if you are, then you're more likely to have a healthy approach reaction to sexual activity. And then the opposite can occur in all of those domains in dysfunction. So negative affect, if you have a lot of anxiety or concern about your performance, about your looks, about things that are involved and wrapped up within the sexual act, then that's going to contribute to dysfunction. Your attentional focus, again, how are you going to be judged by others or your partner if you don't perform well, can be an issue for some people. And you're getting this increased autonomic arousal, but not in a sense that helps you. It can lead to attentional shift or to anxiety. And then once you have that dysfunctional performance, once the behavior is expressed in a way that you're not satisfied with or that you find upsetting, then you create an avoidance feedback loop regarding sexual arousal and wanting to re-engage. Of course, we've got to consider, again, the sociocultural context of a lot of these things. The concept of erotophobia, which is associating sexuality with negative feelings, anxiety, or threat. Some of this comes from sort of the more puritanical essence of some of the founders of the country that we're in. But of course, the cultural context and how your culture teaches you to think and feel about sex and about your own body has a huge influence on your sexual functioning. Of course, if you've had unpleasant or traumatic sexual experiences, either in childhood or adulthood, those are going to have a huge impact and get wrapped up in your understanding of sexuality. For many people who have been sexually assaulted, a really difficult part of that process of coping with that trauma is to be able to have positive associations with sex, to be able to engage in a satisfying or healthy sex life after having gone through those experiences. The quality of your relationships, of course, has a really big impact on whether or not you experience sexual dysfunction. So if you've got poor interpersonal relationships, poor social support, if you don't communicate well, all of these factors can contribute to dysfunction. So as I mentioned previously, education can often be surprisingly effective. I think a lot of people, first and foremost, don't receive a good education in sex through public schools or through families, through parents. So I think there's a lot of misconceptions. There's a lot of sort of misleading evidence and counter programming that goes on just through culture. So simply helping people to understand, that the concerns that they have are not abnormal and that there's nothing to be ashamed about, or helping people just to understand the physiology of their own body or of their partner's body, and the whole process of arousal and excitement that goes along with sex, just teaching people how to essentially be more conscientious lovers, can be really, really helpful with couples and individuals to have a more satisfying sexual experience or to overcome dysfunction. So for a lot of people, it can be as simple as just overcoming some ignorance about healthy sexual behavior. The kind of classic example is, educating both women and men about the necessity of foreplay for the female arousal cycle and things like that. And so this idea that there's a discrepancy in some ways between typical male and female arousal cycles. And so trying to be conscientious of that and to adapt our behavior in such a way that it's mutually beneficial can be something that's quite straightforward and simple. And you can work with couples or even individuals on how to do that. Masters and Johnson were researchers kind of up there with Albert Kinsey as some early researchers in human sexual behavior. They really developed this psychosocial intervention that focused on education about sexual response, foreplay, et cetera, as I mentioned. They also got into the idea of some biofeedback and sort of psychophysiological education, this idea of sensate focus and non-demand pleasuring. So sexual activity with the goal of focusing on the sensation rather than being purposeful just to achieve orgasm. So this ties in a lot with a lot of mindfulness research that's done. When I work with patients, and back when I used to run some groups for acceptance and commitment therapy, there's a thing in mindfulness called mindful eating. So for example, you give the person a Jolly Rancher or an M&M or something, and you have them examine it and look at the color and the feel and the texture, and you just go through this really intense process of tasting it and eating it, and you're really trying to focus on being present in the moment and experiencing your senses. Well, the same thing can be directed towards sort of mindful sexual behavior. So this idea that rather than building up sort of a single-minded purpose of sex, of achieving orgasm, being able to be present in the moment and engaged in pleasurable sensation. And helping people, in doing so, of course, to decrease performance anxiety. So improving communication about sex within the relationship, helping the person understand sort of what constitutes normal or abnormal sexual functioning, and helping them to feel more comfortable in their own skin and within the context of that sexual relationship to perform more effectively. There are some additional psychosocial procedures. There's like some physiological things. There's something called the squeeze technique to try and prevent premature ejaculation. There's mixed evidence on this, but it's really about the idea of a lot of times it's teaching people to engage pelvic floor muscle, some sort of techniques for overcoming physiological sensation in certain ways. But this probably sounds very controversial, but this idea of masturbatory training is often one of the ways that they help women to overcome female orgasm disorder, is through simply practice making perfect. I don't mean to be facetious about it, but this idea of helping women to understand their bodies more effectively, to understand their arousal cycle more effectively. There's a condition called vaginismus, which is a particular type of pain-related sexual disorder, where the vaginal muscles are contracted, and they can use there's a process of dilation that basically allows the person to gradually overcome that muscle tension and to relax enough to comfortably enjoy sex. And then for people that have low sexual desire, sometimes encouraging them to be exposed to erotic material, at least in a healthy way, and sort of try to engage that side of their sexuality that's psychological more intensely, and to provide some content for the development of fantasies and for more of an interest in becoming aroused. So there is a multi-billion-dollar industry focused on erectile dysfunction. So Viagra is the idea of being hailed as a wonder drug, initially when it first came out, which, again, when you look at it in sort of a sociocultural context is kind of fascinating. But ultimately, we know that Viagra, unfortunately, is contraindicated for people with a lot of health problems, some of which cause erectile dysfunction, like cardiovascular, hypertension, that kind of thing. It has a headache side effect for a lot of people, and many people who start or prescribed it discontinue it. There are some more invasive physiological treatments, like injection of vasodilating drugs into the penis. There is a prescription of testosterone, so hormonal treatment. For people that have a physiological issue with obtaining erection who want to be sexually active in that sense, there are penile prosthesis or implants. There's vascular surgery, again, for blood flow problems, especially if you have sort of collapsed vein that's restricting blood flow. And then there is vacuum device therapy. Probably not a big surprise to any of you, but there are very few medical procedures existing for female sexual dysfunction. Clearly, it has not received the medical attention that male dysfunction has. Um, Commonly, what you may see is Levitra used, which is a vasodilator, kind of in the same family as Viagra, but there's some research evidence that shows that it can help with women who are experiencing orgasmic disorder or arousal disorders. But generally speaking, most of the things available surround sort of male sexuality, which, you take with a grain of salt, but that seems to be the case. I have also seen some research on utilizing testosterone amongst women as well, but ultimately, most of the treatment for sexual dysfunction, except for erectile disorder, is psychological in nature. Let's shift gears a little bit and talk about the paraphilic disorders. So the previous disorders we were discussing, excuse me, were really more consistent with issues with sexual functioning. Paraphilic disorders are really about when the process of sexual attraction or arousal is misplaced in an unhealthy fashion. So the person is focused on inappropriate people or objects. There are often multiple paraphilic patterns of arousal within an individual. It's not like everything we look at in psychology, it's very rare to see someone who has one pure condition or fits only sort of one clear box to diagnose them with. Oftentimes people are more complex than that, and there are comorbid disorders, or there are layers within those disorders. There is very high comorbidity, as I mentioned, with things like anxiety, mood, and substance use disorders, and the paraphilias as well. And now this is a bit of a chicken and the egg argument about whether or not these other mood states or if substance use is contributing in some way, or if it's an attempt to cope with or a reaction to sort of the paraphilia itself. So it's a complex interplay between these factors. The DSM-5 lays out several types of paraphilias: fetishistic disorder, voyeuristic disorder, exhibitionistic disorder, frauderistic disorder, transvestic disorder, sexual sadism disorder, sexual masochism disorder, sadistic rape, and pedophilic disorder and incest. So these are sort of the main categories. We're going to very quickly go through each of these to give you a sense of what's entailed, but this is going to be, again, a very quick sort of executive summary of all of these. There are plenty of researchers and clinicians who this is their area of expertise and focus who would be upset with the short shrift we're giving, but it's kind of the nature of the class, right? It's a survey across all these different types and aspects of abnormal psychology. So let's dive right in and talk about each of these in a little bit of detail. So in order to define something as a paraphilic disorder, basically the sexual interest, the urges, the arousal, the behavior, it's manifesting throughout that person's sexual functioning. It's in their fantasies as well. Paraphilia is not always a disorder, though, because remember, if it does not cause distress and if it does not impair functioning, and we might add the separate caveat for these types of disorders is they do not act on urges with a non-consenting person, right? So of course that we can make the very strong argument that that is an example of an impairment in social or interpersonal functioning, right? If you're transgressing people's boundaries and violating their bodies and without their consent, then of course you are not functioning interpersonally. So the thing that I'm kind of getting at, though, is being very careful not to stigmatize and not to judgmentally label people who are not experiencing distress and who are functioning well, who may have, found partners that are share similar types of paraphilias or are certainly willing to engage with and allow them to express those interests in a way that does not cause them distress. So it's important to realize that having a paraphilia is not always a disordered behavior. It is only considered disordered when the individual has significant distress or impairment, or they act on those urges with a non-consenting person, as I said. So frauderistic disorder is one of these paraphilias. This is a persistent pattern of seeking sexual gratification from rubbing up against unwilling others, right? So by its definition, it's a form of sexual transgression or assault. and therefore makes the criteria of being a disorder in that sense. And it often does cause the individual significant distress as well. Now, some of that might be tied to fear of prosecution, but also a sense of shame is often associated with this disorder. It often occurs in crowds or confining situations from which the other person cannot escape. So crowded subways, elevators, places where the person may have some plausible deniability even about the situation. So this is essentially, a disorder, a paraphilia, that the person can only achieve arousal or sexual gratification through something that is transgressive, that is a violation of someone else's rights. Fetishistic disorder covers a lot of ground in the sense that this can be sexual attraction to any non-human objects. These objects can be inanimate, tactile, everything from rubber, hair, feet, typically referred to as a foot fetish, certain objects such as shoes or pantyhose or things like that. A lot of times some of these things are sort of sex adjacent, so things like, as I mentioned, pantyhose or lingerie or things like that, but they can often be much more abstract and disconnected from what we typically think of as sexual arousal. And really, if anything under the sun that you can imagine, people can develop a fetish regarding. So I won't try to come up with an exhaustive list and therefore eliminate a lot of other possible options. But essentially, anything that is an inanimate, non-human object that the person is finding themselves sexually attracted to starts to fall within the heading of a fetish, and it becomes a disorder essentially when the person is otherwise unable to engage in any sort of satisfying or healthy sexual behavior without indulging the fetish itself, when it becomes a necessary component. Voyeuristic and exhibitionistic disorders are somewhat related. Voyeurism is observing an unsuspecting individual undressing, naked, or engaged in sexual activity. And then there's this certain idea we're going back to about the idea of anxiety and arousal being a not black and white concept when it comes to sexual activity. And so for many people who are voyeuristic, the risk associated with quote unquote peeping is what intensifies the sexual arousal. Someone who knows they're being watched or is consenting to being watched is not really scratching that itch for this person in terms of their paraphilia. So again, it's acting upon non-consenting people is what really defines it as a disorder. And a good example of a paraphilia that with a different, healthier expression is not really a disorder. If the person sort of engages with pornography that addresses this issue as opposed to actually going out and doing it, or if they have a partner who's willing to engage in role play or fantasy surrounding this issue, well, not causing them distress, not getting them arrested, not getting them, causing anyone to be exploited or violated. Is it a disorder? Well, technically, no, not under the definitions that we use. Exhibitionism is this another paraphilia where the person achieves sexual arousal and excitement, and it becomes necessary, this thrill of exposing oneself to unsuspecting people, the kind of classic flasher sort of phenomenon. And so, of course, this has a lot of repercussions, again, for being prosecuted, for getting in trouble. And there is something about that risk that's often tied up where the person may not be able to engage with this particular source of arousal in a healthy fashion. But some individuals do find ways of working around this and finding socially acceptable ways, or finding willing partners who are willing to indulge the person in this fantasy in a way. But for some people who have more extreme versions of these paraphilias, that will not satisfy that particular drive. And so it becomes particularly a disorder and unhealthy for them and for the people that are victimized by it. So when it crosses certain thresholds, of course, it does in fact become a pretty significant disorder. Transvestic disorder, which is one that's somewhat it's controversial. I think some people will take offense at, saying that transvestitism, as it's called, is inherently pathological. Of course, it's not. It's only considered disorder if it causes significant distress or impairment for the individual. So it's not inherently pathological to enjoy cross-dressing or dressing in clothes that are typically associated with the gender other than the one the person is. So males may rarely show highly masculine compensatory behaviors. So there's some people who are particularly distressed with themselves and ambivalent about this desire, this level of arousal, and therefore will overcompensate in some ways. But the majority of people who are transvestites do not show these compensatory behaviors. a really important thing that came out of some of Kinsey's research, I think, was an understanding that the majority of males that engage in transvestitism are not homosexual. They're pretty much representative of the normal distribution of homosexuality versus heterosexuality amongst males. And many are married and the behavior are partnered and the behavior is known to the partner or spouse, who does not have an issue with it, who understands this is something the person enjoys and gets aroused by and is not judgmental about it. So this is one of those examples where I think there's less of an objective, there's no victim, essentially, is what I'm getting at. There's no non-consenting person being exposed to or engaged with this. This is much more internal to the individual, and to, in many ways can be adopted into a healthier sex life. It's really has to be seen in context. Now, of course, that's something that's changing over time as society is more permissive and understanding of the full spectrum of human sexuality. You go back 40, 50, 60, 70, 100 years, you might find that this is more of a disorder because the person is being forced to be so secretive about it or is so fearful and anxious of repercussions if they're found out. So again, context really matters for a lot of these definitions of disorder. Sexual sadism and sexual masochism kind of fall under the same thing as transvestitism in the sense that there's a whole subculture of human sexuality, which is typically abbreviated as BDSM, bondage, discipline, sadomasochism, of people that have found like-minded individuals who maybe even match up on being a sadist and a masochist and sort of forming this symbiotic relationship where there are healthy expressions of this. And so I think it's important that, again, along a continuum, there are people who have tendencies towards sadism or masochism in their sexual behavior, but when it crosses certain thresholds and when it becomes distressing to the individual or is causing impairment in their functioning or causing them actual physical harm, we start to discuss it more as a disorder. So essentially, sexual sadism are people that attain sexual gratification by inflicting pain or humiliation or shame upon someone. Sexual masochists are the opposite side of that spectrum, who derive sexual satisfaction or gratification from suffering that pain or humiliation. We do know that aggressive sex fantasies are somewhat common amongst quote unquote normal people. Sadism and masochism are deviant because pain, or can be deviant because pain becomes necessary for sexual gratification. And the issue then is that pain causing permanent damage? How significant is the pain? Is it more symbolic or more practical? So I'm just, being very careful to say that I don't want to, negatively judge or label people as disorder when they're not. But we do see that this is something that when it crosses certain thresholds starts to cause individuals problems, and they do seek help for it from mental health professionals. So it is something you do see within practices in psychology and other disciplines. Now, one I think that we have very little issue about disagreeing upon whether or not this is a disorder is the concept of sadistic rape. And so, again, an entire class to talk about the complexities and the dynamics and the socio-historical context of rape. But we know that some people who commit rape are sadists and some are not. So the question is the person deriving sexual satisfaction from inflicting pain and from violating someone's body? Most rapists do show some paraphilic patterns of arousal, and they tend to show equivalent levels of sexual arousal to both violent sexual and non-sexual material. So, as we know, rape is always an act of violence, whether it's ostensibly so or not, and that it is not simply about sex, that it is about power and about, diminishing the victim in some ways. And for sadistic rapists, that is really at the core of the act. So there's been a melding of violence and sexual arousal in some individuals who have this particular disorder. And I think it's this and the next disorder we're going to talk about, pedophilia, is such a minefield for morality and for how we feel as human beings towards people. So let me speak to that for just a brief moment. So I think we can profoundly disagree with and want to stop people from engaging in behaviors like sadistic rape or pedophilia while not entirely dehumanizing the individuals that are doing it, not making them monsters, so to speak. Because while that is convenient in our narratives of how we think about ourselves and about humanity, it fails to necessarily be productive. I'm not condoning or offering any defense or forgiveness for these individuals, but I do think we have to appreciate that they are human beings nevertheless, and that we have to be very careful of the baggage and the biases that we bring to the table when, especially if we choose to be mental health professionals. So you can work within those boundaries in a practice. Like, for example, I made a choice in my clinical career that I was not going to work with children. I found that, it was too difficult for me to see children suffering, and that I think I would have had a hard time establishing healthy boundaries. I did a little bit of work as a psychology tech in an inpatient unit with children, and it was really hard on me. And I just found that I probably shouldn't do this for a living, the same way that I decided I probably shouldn't do full-time combat PTSD for a living either. I choose not to work with sex offenders as a clinical practice. Like, I don't seek it out, but I've certainly had patients that I've been assigned to do an evaluation, and in the course of that evaluation, or through reviewing their record, I find out that they're a registered sex offender. I don't refuse to treat them, but I do sort of, it prompts me to be very mindful of my reaction to that individual and my personal feelings towards them, and how does that impact my ability to provide mental health services. So when it comes to these types of behaviors, I understand that there's a lot of emotion tied up in it, and there's a lot of anger, which is very righteous and very justified. But I also think we have to try and look at it scientifically, as well as, unfortunately, a deviation along the spectrum of human sexual behavior that leaves victims in its wake and is very damaging to those that are involved. So that's just my one caveat when we're discussing this. That being said, we define pedophilia as a sexual attraction to prepubescent children. Now, oftentimes the term pedophilia is used as a blanket term for anyone that is attracted to or engages in sexual behavior with anyone who is underage, right? Because every government or state has its policy of what is the age of consent, who's considered a minor. In most states, we're talking about anywhere from 16 to 18 is typically considered the age of consent. I think we are slowly seeing a national standard creeping closer to 18. There are still some states where it's less than that. But ultimately, the idea is someone who's not an adult by the legal kind of not, nominal definition of an adult being, 17, 18 years old, depending on what you're talking about. In some cases, 21 for things like drinking alcohol. But these are all sort of like cultural indicators of someone, being of the age, being able to give consent. There are other terms that really capture that whole spectrum of who the person is attracted to. So when we say pedophilia, we are talking about people that are attracted to prepubescent children, children that have not undergone puberty yet. There are a couple of other related terms. There is hebephilia, which is adults who have primary sexual interest in pubescent children, so like age 11 to 14 roughly. And then there is something called ephebophilia, which is an adult with a primary sexual interest in mid to late adolescence, so like age 15 to 18, 19, something like that. So you have this crossover between the legality of what we consider, someone who cannot give consent for sexual activity, where it is both criminally and morally inappropriate by most standards to engage with, and this term pedophilia being thrown around. So the way it's really focused on in the DSM is pedophilic disorder is focusing more on prepubescent children. So the vast majority of people with pedophilic disorder are males. Pedophilia is rare, but not entirely unheard of amongst women. I even right here, you can see my own judgment creeping into my slides, because I believe originally I had this as vast majority of sufferers. I added the word perpetrators. That is my own bias, right? I struggle with empathy and not being judgmental towards individuals who are harming children. It's a base response most people have as human beings, right? We have an evolutionary pull to want to protect children. And for those of us that are parents, it's particularly strong. So that's just one example of me being, a little judgmental in my own way, of course, and I think arguably with some good reason. But you have to try and distance yourself from that. That being the case, it's kind of like the same thing when we talk about someone succeeding at committing suicide. The language makes us uncomfortable, the same way that for me, simply labeling someone as a sufferer fails. It sort of negates the existence of the victim in this case as well. In some cases, pedophilic urges are limited to incest, that is, young members of one's own family. That's why pedophilic disorder and incest get overlapped a little bit in the DSM-5. An important thing to consider, and this is again not to make someone a hero, but if we want to try and develop empathy, for a very brief moment, for an uncomfortable thought experiment, imagine if what you were attracted to was something that was considered off limits, that was considered immoral, that had really serious ramifications for your life, that you don't have a real sense of control over. I think that's the thing people don't always fully grasp in trying to have some sense of empathy for people in the situation, is that there are many people who would meet the criteria of a pedophilic disorder, who their primary and perhaps only sexual attraction is to prepubescent children, who do not act on those thoughts, do not act on those desires. So you essentially, what you've got is there are people that have the disposition, have that sort of unhealthy aspect of their sexual behavior, who do not act on it, and for a variety of reasons. And then we know that some people that do act on it engage in what are called compensatory moral behavior, which is really rationalization, an attempt to destigmatize, to remove the judgment of, to justify their actions somehow. And there's even organizations like NAMBLA, which are these, really sort of horrific organizations that are trying to normalize sexual relations between adults and children. So this compensatory moral behavior can sometimes be, it's pretty despicable, but the idea of, trying to justify the behavior in terms of claiming that the child derives an educational experience of some kind from being sexually assaulted, or that, sort of not recognizing that it's inappropriate in that sense for children to engage in sexual behavior. So therefore the person is deriving pleasure from it. This person happens to be a child, right? Or, of course, the really despicable argument that pedophiles will often make when caught, that the child was themselves sexually provocative to them some way. So I think that's something that we have to consider, is that people will do backflips to justify behavior which society generally looks upon as sort of like one of the worst things you can do to anybody. So incestuous males may be aroused by adult women in the family. Male pedophiles are usually not aroused by adult women. Like I said, the exclusivity of their attraction is what really is the crux of this problem. Like I said, some will rationalize the behavior and try to justify it in a variety of ways. They will try to take sort of the power differential out of it and make it more, they'll argue that it's more a consensual relationship, when of course researchers and legal experts would argue that the individual cannot give consent. Of course, the thing that we want to, there's sort of a profile that we associate with pedophiles, and again, this is a stereotype, but it's a stereotype based on consistent evidence. So it's not, what I'm getting at is that not every pedophile meets this profile, but it is consistent to some degree, and that is people that tend to be passive, they tend to be impulsive, they tend to abuse alcohol, typically to decrease their inhibition. They tend to have poor social skills. There is some argument that they may have some brain dysfunction. There's a whole fascinating aspect of true crime that looks at both serial killers and pedophiles, and they have a incredible concordance rate of having a head injury in childhood. Not to say that every person who's a psychopath or a serial killer or a pedophile had a head injury, but they do seem to have a higher rate of them. So maybe damage to the frontal lobe is a factor here at some point in some situations. Of course, not everyone. Victims of pedophiles can be male or female. They can be children. They can be very young adolescents. But as I said, there's sort of different definitions for other types of inappropriate sexual arousal disorders. The victims obviously are seriously affected by this, and it's important that we don't forget that while we're trying to in a healthy sense, pathologize individuals who engage in this disorder, I think it's very important that we don't forget that one aspect of the disorder is transgression on non-consenting individuals, in this case, children. So physical symptoms, nightmares, acting out, inappropriate sexually focused behavior themselves. We know that a fair number of people who engage in in sexually abusing children themselves were also victims of sexual abuse. So there's a whole host of a network of horror in here, that can contribute to these things. But ultimately, I think it's important that we recognize that as psychologists, even if we maybe don't naturally muster a whole lot of empathy for people, that does not mean we shouldn't study it, understand it, and hopefully develop effective treatment if we can. Like I said, most pedophiles and incest perpetrators are male. The use of physical force amongst pedophiles is actually relatively rare. Usually they utilize other forms of manipulation, which also, again, really speaks to the idea that children are not able to give consent. They can be psychologically manipulated more easily than adults can, and therefore are more prone to being preyed upon in situations like this. So, as I mentioned, people who fit into sort of a profile that's typical of pedophilia have a really hard time forming quote unquote normal relationships. They may have significant deficits in understanding in their sexual experiences and knowledge, and they frequently are showing a pattern of interpersonal problems starting very early in childhood or adolescence. They may have early experiences that lead them to associate sex in an unhealthy way by chance, and then is reinforced through fantasy and masturbation. So there's a conditioning process where the person sort of gets off on the wrong foot, for lack of a better term, and then becomes sort of narrowly focused in their arousal cycle around that unhealthy attraction to children, for example. They often have a very high sex drive or a very high libido, and so the person often feels compelled to act upon these thoughts, and suppressing those unwanted fantasies may paradoxically increase them. So this is that sort of salience effect where the person is, their efforts to say, don't think about that is really not effective. The way that our brain tends to work linguistically, all you hear is the content. You don't hear the qualifier of don't. I use this as an example sometimes with patients when I'm teaching them about mindfulness and how we can't just suppress negative thoughts. And I'll say, close your eyes and don't think about a pink elephant. Don't hear the sound of its heavy feet hitting the ground. Don't see its pink scaly skin. Don't see its tail swinging back and forth as it walks by. It's a dumb little experiment, but as I say that, the person's like, I'm imagining everything that you're saying right now. I'm seeing those things in my head. My brain just naturally fills in the blanks. And so when a person has an aversive thought and you tell them, well, don't think about that, what you're essentially doing is you're bundling up a lot of energy towards not thinking about that thing, which in fact is kind of like putting fuel on the fire. So you combine this very powerful compulsive libido with an inability to suppress these unwanted fantasies, and you have a person who's in great tension who may feel compelled to transgress. This is a model from your book. This is figure 10.6 that kind of lays out the course and the causes of paraphilic disorders. So typically speaking, it begins with early inappropriate sexual associations. They may themselves be victims of sexual assault, but it might just be some accidental vicarious exposure to something. Possible inadequate development of the idea of consensual, healthy adult arousal patterns. So the arousal pattern gets locked into this inappropriate interest or arousal focus. If the person has inadequate social skills, they don't relate to adults very well, they become kind of locked into this less developed mindset, and they then start to feed as they become adults and as they get older and become sexually active, at least psychologically. They really begin to associate their masturbatory practice with those inappropriate sexual fantasies, and they may go through repeated attempts to inhibit this, and they have this increasing amount of fantasies and compulsion, and then eventually they engage in the paraphilia of one form or another. So how do we go about treating, intervening to help people with paraphilic disorders? So first of all, you want to identify and target the quote unquote deviant, inappropriate sexual association. You want to help the person to really clarify and lay out what the nature of the paraphilia is, and where, what it looks like, what its structure is like, what is the process that you want to start working on and trying to change. There's a process called covert sensitization, which is where you imagine aversive consequences in your mind while also thinking about the paraphilic behavior. It sounds overly simple, but the idea is that you're just simply training your brain through negative association. There's something called orgasmic reconditioning, which is where the person is encouraged to utilize only appropriate adult stimuli, and sort of try to shape their fantasy material that they utilize for sexual gratification to be more appropriate and involve adults who potentially could be consenting. You can utilize aversive conditioning a variety of forms. I mean, people don't, there's certainly been years of people undergoing pretty primitive and dangerous electroshock therapy and things like that, but there are other ways that are less dangerous to engage in extinction or aversive conditioning of these interests. Assertiveness training and social skills training tries to treat the underlying context, which is if this person felt more comfortable with themselves and more able to communicate with other adults, they might be more compelled to form adult relationships. About 70 to 100% of people who are treated for paraphilic disorders show some improvement. Unfortunately, the most paraphilias, most paraphilias run a chronic course and relapse rates are high. So it is one of those problems that's very difficult for people to shake. The poorest outcomes are for people that are more extreme in the behavior. Obviously, people who engage in sadistic rape often have very strong sociopathic, psychopathic tendencies, which we'll talk about in chapter 12 a little bit, which tend to be very resistant to change, at least for most of the adult life. Persons with multiple, more complex paraphilias, it's a more tangled, net to unweave, and people often have a less successful outcome with treatment. But ultimately, the idea is trying to retrain the brain in a variety of ways to break some of these connections between the unhealthy stimulus and the healthy sexual arousal. So the efficacy is mixed. As I said, the poorest outcomes are for people that engage in sexual assault and people with multiple paraphilias. It's difficult to treat incarcerated offenders. So there is a chronic course and a higher relapse rate. Outpatient treatment tends to be more successful rather than treatment in incarceration. But the idea essentially is that people have to be interested in seeking treatment, they have to engage with it, and they have to be motivated, I think, internally, intrinsically, as opposed to staying out of jail. If a person develops a more intrinsic motivation for change, I think they're more likely to be successful, and the research would pretty much hold that up. There are some drug treatment interventions for paraphilias, especially for pedophilia and people who feel compelled to rape. Cyproterone acetate, which is what might be referred to in some circles as chemical castration. This is basically a medication that reduces the desire and the fantasy dramatically, but is only effective while the drug is being taken. So the person has to commit to taking it consistently, or in some cases is mandated to take it, which introduces a lot of ethical questions too. Depo-Provera, which is originally, I believe, developed as a birth control medication, can be utilized to reduce testosterone and therefore reduce some of the libido in males. It is most useful for really dangerous sexual offenders, and some will take it as they'll be compelled to take it to avoid going to prison. So you do occasionally see plea deals where the person has to agree to take a chemical castration treatment to avoid jail time. So the context, of course, of engaging with treatment really matters a lot. We're going to switch gears now and talk a little bit about the construct of gender dysphoria. Gender dysphoria is most commonly, in common language, the sense of feeling trapped in the body of the wrong sex. So gender dysphoria is not synonymous with someone who is transgendered, but for some people who are coming to realize and identify as transgendered, there is a feeling of gender dysphoria which precedes that. And the person often wants to resolve that dysphoria, to resolve that conflict, that that dissonance between their biological sex or gender and then their presentation. And so often the solution for resolving gender dysphoria is assuming the identity of the desired sex. The causes for this for gender dysphoria are unclear. We know that people start to develop gender identity by as early as age 18 to about 36 months of age. Fluid or cross-gender identity, again, to emphasize this, is not a disorder unless it causes significant distress or impairment. Transgender people have been profoundly targeted and marginalized and victimized and are murdered at an incredible rate in this country and others compared to the average person. And so I don't want to in any way, negatively label people that are seeking to resolve gender dysphoria through embracing their identified gender. But when it does cause distress and when it does cause impairment in functioning, it can be considered a disorder that is at perhaps an early stage of someone who will eventually transition. It is relatively rare. I'm glad that it's receiving attention, that we're starting to, pay more attention as a society to, as I said, a very victimized and marginalized subculture, but it is a relatively rare phenomenon. It's more common in males than in females, between 5 to 14 per thousand versus 2 to 3 per thousand in females. The rates are similar across cultures, which is kind of interesting when you think about what's the cultural influence. Some cultures do revere individuals with non-traditional gender experience. So, for example, there are some cultures where a biological male adopting a female role is seen as an important spiritual figure or a shaman. So it's not every culture that sort of stigmatizes or denigrates transgender individuals, but it certainly is probably dominant, at least in the West. So there is no clear biological cause that we can identify yet to sort of figure out what's causing or what the etiology of gender dysphoria is, but we think it's likely that it has some genetic component. Studies have found 62 to 70% of variance in gender expression can be explained by genetics. Exposure to certain hormones in the womb may be a factor, such as higher levels of testosterone, masculinizing a female fetus, or vice versa with estrogen. So it's really not entirely clear, but we think that there are some, biological factors at play. So if the essence of gender dysphoria is the discrepancy between the person's sense of gender and biological sex, one of the ways in which you essentially treat gender dysphoria for those that wish to transition is through sex reassignment surgery. The person needs to be psychologically, socially stable and live as their desired gender for several years prior to undergoing these surgeries, because primarily they're largely irreversible, and there is sort of a common wisdom that the person needs to be absolutely sure before undergoing such a significant procedure. 75% of people who were undergoing gender dysphoria report satisfaction with their new gender identity, and female to male conversions seem to adjust better than vice versa, just on average. There's an unrelated issue, but well, I guess a related issue, but separate issue of intersexuality. So intersexuality is essentially people that are born with aspects of both sexes at birth. In some cases may have both sets of genitalia, that kind of thing. Traditionally, this is something that happens more often than we realize. It's still relatively rare, but when it does happen, traditionally there's been a decision made, often going back in history by sort of a patriarchal medical establishment, to say, well, we're just going to look at the situation as it is and we're going to make a decision and essentially treat with surgery at birth. And the subsequent gender dysphoria that may come with that may need to be addressed, because the person might identify and feel more like the gender that they were not essentially converted to via surgery because of their intersex status at birth. So these are, rarities of rarities, but certainly issues that can cause the individual a lot of distress. So an important distinction here is the idea of gender nonconformity, which is quite common in children and may not necessarily lead to gender dysphoria. So it's much more likely for children to engage in gender nonconformity than it is for someone to grow into adulthood and necessarily feel that sort of stronger acute distress associated with dysphoria. But gender nonconformity can lead to some negative social experiences. Unfortunately, kids can be bullied or targeted for these issues. And there's a conflict between confirming the child's identity, trying to empower them to feel as they feel and to be comfortable with themselves, but also this maybe pull to encourage cisgender or more, cisgender is essentially the same biological sex and gender expression, if you don't know. So the idea then is sometimes a conflict between wanting the person to take the path of least resistance, so to speak, and to adopt more of a cisgender role so they'll be more socially accepted. So in a sense, you're treating the underlying societal problem rather than the individual issue with that child. But the treatment needs to be specific and individualized to that child's needs and environment and their particular set of psychology surrounding this issue. So let's just summarize here. Sexual dysfunctions are, I should say, not very common, very common, and they can be across all aspects of the human sexual cycle. So it can be related to desire, arousal, and/or performance, orgasm, things like that. We know that paraphilic disorders represent sort of inappropriate sexual attraction, often to inanimate objects of one form or another, and often become the sole focus of sexual attraction. So it becomes sort of a necessary component for any sexual satisfaction. There are some psychosocial and some medical treatment options that can be efficacious. Really a comprehensive assessment process and a treatment approach that pulls from all effective modalities is usually best. And then this idea that's unrelated but is covered in the same chapter is the idea of gender dysphoria, which is, of course, at the top of consciousness in our culture right now, and sort of in the movement for LGBTQ in general, individuals to be more accepted in society, but the specific focus on transgender people as well, partially in response to a lot of unfortunate legislation and hate that tends to target them in ways that I believe are unfair. So an experience of gender dysphoria is essentially being trapped in a body of the opposite sex, of feeling an incongruity or a disparity between, or a dissonance, if you will, between the way that your body is and the way that you feel internally in terms of your psychology. All right. Well, I will see you for the next lecture then, which will be coming out very soon.